Just a minute, I got to get the picture in here too. Where you stand. No, I'm still myself. So we're going to start this over again. I'd like to introduce Diane Mosnik, and she can tell you a little bit more about herself and how she got started with FASD.
All right, thank you. Thank you for everybody's patience as we work with our technology. So as I was saying, I got started in FASD when I was an undergraduate. So I'm from a small town in northern Minnesota. I don't know if any of you have heard of it. It's called Ely, Minnesota. It's right on the Canadian border. And, you know, when I was young, of course, I wanted to get as far away from my family, but not too far. And so Minnesota at that time had reciprocity with North Dakota. So I ended up with my brother and sister at North Dakota State University. Woo-hoo, NDSU, go Bison. And I was on I got a research and a teaching fellowship, and I got hooked up with a professor who did fetal alcohol spectrum research. So I was fortunate enough to travel. We drove our cars and rode in little, I don't even know what you call them, cylinder top planes, right, with 2 to 4 people fit in these planes, and we flew all over North Dakota, South Dakota, and Minnesota, the Indian reservations and people's homes and facilities and group homes, and I tested children of all ages on the spectrum for fetal alcohol. And let me tell you, some were in drawers, some were in the table, some were sure hyperactive, some had serious facial dysmorphology, and some had very mild deficits. So I got to see the entire spectrum, and I did neuropsych testing, and then we did neuroimaging work. And so I've got some published papers in the area, and that was one of the reasons why I became a neuropsychologist. And so I actually got exposed to fetal alcohol at a very early age before I even had really decided my career path. And that sort of laid the foundation for me, and so here we are. I think one of the other things I want to mention that's sort of different about me than traditional neuropsychologists, I'm trained because I, unfortunately can't get enough of school. Ask my parents. I'm trained in both pediatric and adult neuropsychology, so I know the entire developmental age span. So I do autism and FASD across age. My model is 2 to 102. And I am also trained in psychiatry and neurology. So I've worked on the medical side of things as well as the pediatric side. So I'm familiar with the medical and physical complications or comorbidities associated with a variety of diagnoses. And again, both pediatric and adult populations. So I think that makes me a little bit unique compared to traditionally neuropsychologists. You choose, you're either pediatric or adult. Which has always been fascinating to me because, right, life doesn't end or start at 18, right? And many diagnoses, so much of what we deal with, except for really dementia, starts in childhood, right? Autism doesn't stop, and people don't die when they turn 18. Neither does fetal alcohol spectrum. So what happens when these people turn 18, and even when they're getting close to 18, most of the pediatric neuropsychologists don't want to follow them or don't know what to do. They don't have resources for going into adult or transitioning into adulthood. And the adult neuropsychologists don't know the developmental conditions, right? So I'm like, well, what is supposed to happen to these people when they hit 18, right? Or when they're 17 and you're trying to plan for adulthood. So that is a difficulty. And as I'm sure you've heard when the panel was still here, we were talking about some issues with neuropsychology in general, of not being willing to, I guess, take a stand and make a firm diagnosis in a lot of areas and relying on physicians. My experience, because I trained in hospital settings, most of the physicians came to the neuropsychologist for the diagnosis. So I was trained from a medical model that we do the testing, we make the diagnosis, and we tell the physician, right? So not the other way around. And so that data, because they don't do the cognitive testing, they don't do all that, the functional screens and the profiling. So that's the model that I come from. So we were trained to, we make the diagnosis, we work with the physician, and then the physician adds in the medical piece, but we contribute to that. So we don't, not make a diagnosis. But unfortunately, a lot of the programs don't train that way. So it is important. And I feel it's important for me to help educate families and other providers that you need to tell the neuropsychologist that you're working with You know, that a diagnosis needs to be made. Without a diagnosis, it's pointless than doing the evaluation. So kind of what questions do you ask a neuropsychologist and that sort of thing. What my talk is really going to focus on is neuropsychology, because that's what I do. But what I want the reason I want to focus on neuropsychology, I'm going to talk about the cognitive deficits, all the adaptive functioning, and the functional screen, but I want to talk about it in a way that you can understand that there is a biological and neurological basis for what happens. Now, although there's comorbidities and similarities in the diagnosis to a variety of other diagnoses, there are differences, and those are important to understand. And then how that relates to neuropsychology and the evaluation, and how that relates to them functioning in real life. And then I want to also talk about this and think about this as children transition into adulthood, early adulthood, and make it through adulthood as they go on, and transition for a variety of reasons, right? Living situations, job situations, relationships, that sort of thing, legal system, unfortunately, right? So I want to think about that. And then a topic that has two angles, I guess, maybe one a legal and one sort of just conceptual, and that's assisted decision making. So I have lots of information in the slides, and I put it in there because I want you guys to have that. So Jackie will have a copy. I'm also happy to email that to anybody if you want, you know, slide copies online, since I did print, unfortunately, forgive me, 6 slides to a page, so a little difficult to read, and I'm trying to be as green as possible. So I'm happy to email the slides so you can have access to that. And there's some websites and stuff also that you can cut and paste from the slides themselves that might be helpful. So I don't need to get through all the slides. I want to make some major points, and I want to be interactive. So I want to be a resource for you guys. Please feel free to jump in, ask questions. Let me know what you're thinking and what your thoughts are and what you guys need from me. So anybody questions to start out with? Yes.
To start with one that kind of made me wonder, like, we got a diagnosis of FAS or second grade. We really didn't get any services out of anybody until we got autism. Why does the diagnosis of FASD drive no services currently? And so it's like, we're all talking about it, but to me, the bigger, or one of the bigger pieces is, with this diagnosis, once it's even made, you still can't get nothing out of the system.
You know, my first slide, I'm talking about challenges for the field, right? And this was a big one. Really, we didn't have, myself as a neuropsychologist, I didn't have a code, right? I didn't have a code, a diagnostic code to use for fetal alcohol spectrum disorders until DSM-5 came out, the current edition. So I had no code to use. What happens when you don't have a code? Nothing. Nothing happens when you don't have a code, right? Insurance doesn't recognize it, doesn't get paid for it. You don't qualify for any services, nothing, nowhere, right? The DSM came out, what, summer of 13 or 14? Less than 5 years, yeah. Yeah. And so there was a medical code, right? But it was only for the severe cases of fetal alcohol syndrome that had the full dysmorphic. So we're going to talk about some of the diagnostic criteria. And just like autism, right, while the numbers have increased, it's because the perception or the spectrum of the disorder has really been fully recognized, right? And I did, certainly not going to tell you my age, right? So I'm not going to tell you when I was traveling around North Dakota and South Dakota, but way back then we knew there was a broad spectrum of fetal alcohol disorder, right? From very severe cases with completely split palates, right? Severe cognitive and brain deformities to very mild deficits. And so this is 25 years ago, and we knew this, and it's taken this long, right? So there's been research published, there's been neuropsych published, and it's taken this long to have an impact, right? And the difficulties are multifold. So one of the major is the first line here, right? People are reluctant to raise this question, and they're reluctant to evaluate. Still, it's less than 5% of neuropsychologists ask the question in their interview of whether or not the mother drank alcohol during their pregnancy. Why do you think that is? Absolutely. Right? Now, but the neuropsychologist or the psychologist is afraid to ask. Right? You don't want to start out pissing off the collateral informant that came with you that brought the child, right? You don't want to, look at it as accusatory, right? And blaming. They used to believe the mother, that mothers get blamed for everything, right? The schizophrenic mother, the cold mother, the refrigerator mother, right? Caused all these things. So many providers and medical providers as well don't want to ask questions, okay? But then, once the questions started being asked and people recognized this, there wasn't a code and nobody knew what to do. So there weren't resources out there for you to have. So even when you got a diagnosis of FASD, nobody knew what it was. Nobody knew what to do for it. Right? There haven't been any group homes. This is the first group home, right? And this is important because as I go through the neuropsych, you can see while there's overlap in what appears to be the diagnostic criteria, the presentation, right, of what we call attentional problems or executive problems or memory are different in FASD than they are in other, what I call them, other alphabets, right? ADHD, ODD, CD, right? Any letters you want to use. The presentation is different, and we need to be aware of that. But until we get to diagnosis, that is the first step. So even like dementia, I believe it's so important to have an accurate diagnosis because without that, even when there aren't resources, we'll never get resources specific to that group if we don't start with giving up the group, right? So if we call everybody senile dementia, then we'll never know that some have frontotemporal dementia, some have Lewy body disease, some have Alzheimer's, some have a stroke, and they need different treatments. So we have to start with the correct label. Autism, unfortunately, has been around for a very long time, so has fetal alcohol, but it didn't have as much of a stigma, although there was a stigma, right? Same thing with schizophrenia. There was a stigma, and there was institutions where they, put people. But it's such a larger population of individuals that suffer from autism, and they just like we're doing now, we're motivated and started with grassroots efforts and got resources out there and diagnoses out there, and now there's lobbyists, right? So now the courts have gotten involved, and when DSM-5 came out, right, instead of the individual diagnoses, now we have an umbrella diagnostic code. So we used to have Rett disorder, right, Asperger's, PDD, NOS, childhood disintegrative disorder. Even though they were all under the umbrella of autism spectrum, the insurance companies, they do their little tricks, right? If it's not autism, we're not paying for anything. So then the government gets involved, which should be science and medicine, and says you have to cover autism, and then the insurance says we don't want to. Now everything's called autism because the insurance companies are mandated to pay and cover for those services, right? So that movement has taken years, and that didn't happen until the new DSM-5 either, where we have the umbrella term, so now all autism services have to be covered by insurance. So unfortunately, those are slow moving, right? So, but we're getting there, right? And the other reason that autism helps because so many of the features of fetal alcohol overlap with autism spectrum as well as ADHD. And autism and ADHD are more well known by neuropsychologists, so they're sort of the default diagnoses. They often get misdiagnosed as autism or ADHD, but that's helpful because then get them into arenas where they get services, right? But we're getting there. So we need the diagnosis to get the services, but then the diagnosis isn't helpful unless you have services tied to it. So we've got sort of this vicious cycle going on. Okay. So neuropsychologists have traditionally felt they were dependent on physicians to make the diagnosis. Again, I think it needs to be an interactive. There's enough research out there for psychologists, neuropsychologists to have evidence-based medicine to know what to look for, but many of them are not specifically trained. And again, there's this discrepancy between the pediatric and the adult neuropsychologist that prevents a lot of that communication. Okay. I'm going to skip some of this. I'm going to get over to the, so we've been talking a lot about the functional screen and some screening devices. One of the difficulties in the field is it's very difficult. It's a complex disorder. It's a spectrum, right? So it's hard to find a screening instrument that can really tell you whether or not a person meets criteria for fetal alcohol spectrum. We have medical criteria, right? So we know the physical, facial dysmorphology and the other physical and brain characteristics that need to be evident. But we now know that with or without the facial dysmorphology, there's a significant range of cognitive impairment. There can be worse cognitive impairment with fewer facial features, and some can have severe facial features but have less cognitive impairment. So they're not directly correlated. And also the impact of those deficits on functioning varies greatly and is much more significant impact in fetal alcohol spectrum than it is in autism or ADHD, because the areas of the brain that are affected are more global. Okay? I just put this in here. This is actually, I'm going to touch on this at the end, but I want this to be in your minds as we go through the neuropsych, right? So what are the needs of our clients? So the biggest thing that has stood out for me when I work with families and with individuals, either their own biological children or many through foreign adoptions or local adoptions in the United States that have been exposed to alcohol in utero and have fetal alcohol spectrum characteristics, right? They need assistance with structure in their life, right? And you know, you talk about it as Courtney, you know, you talked about so beautifully, you know, this is the life of FASD, right? You're saying we're still learning. You are never going to stop learning, right? Anybody who knows anybody with FASD, it is a continual changing, right? It's amorphous, it's like slime, right? Flips through your hands. As soon as you think you got a handle on it, whoa, what happened? I don't know what I'm doing. That's FASD. It's so different than other diagnoses. This is people with ADHD, right? Once you figure out what their deficits are and you do these things, you just keep those things going and you're set. Autism, same thing. You got some, you know, circumscribed deficits. I tell you what the neuropsych profile, you do these things, and you're good to go. You can stay on the straight and narrow. That, sadly, is not true for fetal alcohol spectrum. There's so many other issues, and it's this amorphous and constantly changing reaction to the environment and emotional and behavioral regulation. All of it is disrupted. The systems of how parts of the brain communicate with other parts, especially the frontal lobe and the cerebellum. This regulates behavior in all aspects, sequential movement, steps, planning, decision-making, but on multiple levels. Right? In autism, it's just difficulty making a choice. We can work with that. In FASD, it's so much broader, and all brain areas and systems are involved. And sometimes they work really great, and you're like, wow, that just clicked. And the next day you're like, whoa, nothing is clicking. And the patients, right, the individuals, both as children but certainly as adults, the deficits functionally often are greater than they look like on cognitive testing. There's this disconnect between the numbers on performance on neuropsych and what they actually can do in real life. So tying that together, that's been a goal of mine when I do the neuropsych, to tie it into what's happening in their real life and how can I measure that. So I use a lot of tests and try to stay current on tests and design tests that are not used by typical neuropsychologists, because trying to get at these deficits that impact their functioning in their adaptive life. Okay? So that's a difficulty, but the individuals themselves react to intervention differently. Right? So they need structure, but they don't want structure, right? So they're not cooperative with you. So you got to do this sort of side along. I'm sort of helping, guiding, but no, it's totally your decision. Yeah, you got this, but I'm just going to give you this hand, but I'm not really here, but I'm going to be here, but I'm not really here. No, sure, okay, right? So you're playing this dance of telling them what to do, but not telling them what to do, guiding them, but letting them make their own decisions. So how do you give assistance and support without giving assistance and support? So that's a huge thing in FASD. I'm sure all of you, I see some smiles and recognition, are dealing with that. But we need balance between this offering support and structure, but not controlling or commanding. This goes along with this concept of assisted decision making. And we're going to talk about that. So how do we do a collaborative approach but still give enough structure and guidance? Because, right, they're so vulnerable and there's high risk for involvement in the legal system in so many areas of their life. They really can't manage themselves even when they think they can, right? So that's a continual thing. We have come a long way, right? So now we have code. It's available for insurance. More resources are coming, but we're also overlapping on resources available for other diagnoses: ADHD, mood disorders, mood dysregulation, autism. Lots of resources for autism will work with fetal alcohol. So we're kind of tag teaming and overlapping on some of those resources. The American Academy of Pediatrics has a wonderful toolkit. They describe. These are, I just have one copy of these. They're on the website. This is just an example. So the American Academy of Pediatrics has a toolkit, and they have the first one is a flow. Well, you can look through them. Yeah, so there's the flow chart for medically how to make the diagnosis. There's a functional screen that you can use, that teachers can use. There's one that the juvenile justice system uses to click off symptoms and behavioral issues. So some more guidance for pediatricians, certainly. This is not right, and this should also go to family practitioners, right? Because many individuals come to me as adults and need a diagnosis, right, or late adolescents. So pediatricians are not working with those people, so we need to get this disseminated into adult physicians as well instead of just the pediatricians. But obviously progress is being made. There are other valuable Centers for Disease Control also has a wonderful website and evidence-based medicine for working with FASD, a lot of resources. They have online webinars and training. The Canadian Physicians Health Centers also has wonderful resources. They have kind of a flow diagram also for assessing, diagnosing fetal alcohol and getting resources, disseminating. So they have a wonderful organization. The National Organization for Fetal Alcohol Spectrum and NOFAS, and then the Minnesota organization in particular has been very active in disseminating online tools and resources and training as well. So current classification. So we have the ICD-10. So now the world that we're on to ICD, and this is the international classification of diseases, medical diagnostic code. So we have the P diagnosis is for newborns that are suspected of being exposed to alcohol. The Q86 is for fetal alcohol syndrome, which has the full dysmorphic variant. And then there's other diagnoses that we can use that are associated, right? So failure to thrive, some physiological deficits. They use sort of symptom codes to get at aspects of fetal alcohol if they're not severe enough to meet the full code. These are some medical codes. When DSM-5 came out, now we have some diagnostic codes. F88 is it's still, unfortunately, it's not FASD specifically. It's other specified neurodevelopmental disorder, but you can specify them associated with prenatal alcohol exposure. So that's the one that we can now bill for fetal alcohol spectrum disorders. Okay. There's also now a new code that's being researched and studied to come out hopefully in the next version, which is called the neurobehavioral disorder associated with prenatal alcohol exposure. So it's actually going to be the title, but that's essentially what we're working with now. So we use the F88 code. ARND, which is alcohol-related neurodevelopmental disorders, alcohol-related birth defects, and spectrum. So these are all terms that are sort of used synonymously in the research field when we look at for evidence-based medicine. Okay. Nerve toolkits. So the Canadian and the American have these are the scales that I'm passing out. So you guys get a sense of what those are. Flow charts. So to make the diagnosis of fetal alcohol spectrum, we have facial dysmorphia that needs to be diagnosed. There's growth problems, right, that the individual experience. Central nervous system abnormalities, and there's 3 areas in there. So there's structure, neurologic symptoms, and the functional symptoms, okay? So the structure includes the head size, so microcephaly, so they can have smaller than normal head sizes. They can have micronaphia, which is a smaller jaw. The lower jaw is smaller. Smaller ears, so there's some differences in actually the size and development of the head. There's brain abnormalities, so there's structural abnormalities that can be found on brain neuroimaging studies, and we'll show you some of those. There's also neurologic soft lines. When the neurologist or the physician does the neurologic exam, there's what we call soft lines, so they're not hard in the sense that they indicate, oh, this person had a stroke, so they're left hemiparetic or something, but they're signs that should have developmentally gone away as the child develops, and they don't. So these are called non-specific soft signs, but there's a higher incidence present in fetal alcohol spectrum. Then functional, that includes all the cognitive deficits, intellectual deficits, learning disabilities, and the adaptive functioning. All falls under that domain, okay? And then there's a measurement of a criterion that says you have to have, right, maternal alcohol exposure. And that's either confirmed or unknown, and there's ways to kind of estimate or guesstimate whether or not there's been prenatal exposure to alcohol. So like in foreign adoptions, that sort of thing, there's evidence we can use if we can't get that data, okay? So this goes over, I'm sure all of you are familiar. I'm not going to spend a lot of time on what the physical features are. This shows you, but obviously the eyes, both the epicanthic fold and then the diameter. So both either the horizontal and the vertical measurement of the space between the eyelids is different, tends to be smaller in FASD. You know, ear abnormalities, the low nasal bridge, obviously the philtrum and the upper lip. So this tends to be flatter and there's a thinner upper lip. But again, wide range of severity, right? And we can go from partial cleft palate to full cleft palate, where the entire upper surface of the mouth, upper lip, nose, everything is clefted. So never sealed. So neural tube defects in the brain. And we talked about overall brain size in addition to head size. So there's microcephaly. The brain itself is smaller. Regions of the brain are also smaller in addition to the whole brain size. There's also abnormal development of cells. So cells themselves do not migrate appropriately or consistently in the brain of fetus in much more widespread areas, which is not the case in things like autism. And there's also deficits in neurotransmission, so how the cells communicate with other parts, cells in other parts of the brain. Okay? Corpus callosum, I'm going to show here a beautiful picture of the brain. Yes. The bright red area in the middle is a huge bundle of what we call white matter tracts. So it's a huge fiber tract that connects the left to the right hemisphere. And this is a section right like if my nose was sliced and you were looking at the side of my brain in the center. Okay? So we have a left hemisphere and a right hemisphere, right? And they're connected. There's actually a big fissure down the middle of our brains, and they're connected by this, you know, in the brain, it's not red, but this big red collection of fibers, and this is smaller in size, and you can see this is an affected brain over here. You can see the whole brain, look at the difference in size, but also the size of the corpus callosum is much smaller here. In addition, the cerebellum, which is in the back part of our brain, which is used, it has intimate connections to the frontal lobe of our brain. So the corpus, or our cerebellum, is responsible for coordinated movements, sequential steps, motor movements. Like when we learn to ride a bike, it teaches us to how to get there, and then once we get it there, it's sort of hardwired into our cerebellum. But the cerebellum can't work without communication to the frontal lobe, and the frontal lobe is what puts it all together, right? It coordinates your motor movements, the timing, the sequencing, decision-making. So those two need to work in concert, and they're both affected significantly by alcohol, okay? The hippocampus. So this is an actual picture autopsy of a brain with fetal alcohol. So this is a healthy baby over here, healthy baby. You can see the size, and this is same age and other factors corrected. This is a baby that's been exposed to alcohol. So you can see even the pattern of the sulci and gyri are not the same, and certainly not as large as the brain of a healthy baby. This is neuroimaging. This is an MRI scan of the brain. So you can see over here on this side, this is the nose. And this is, again, placed to the center of the brain. And you can see here's the corpus callosum, very thin, straggling. There's a lot of space around it in an affected brain. Okay? And the hippocampus is an area of the brain that's responsible for learning and encoding new learning into memories and the storage of memories, and then communication with the frontal lobe for people to access and utilize those memories. And those are significantly impacted in fetal alcohol. So they don't learn as well, they don't store information, they don't retrieve that information and apply it to real life as well. So all pieces of that can be affected in fetal alcohol. Okay? You can see obviously how that has, as I was hearing you talk earlier today, you can see how much impact that has on daily functioning, right? The basal ganglia are the motor cells deep in the brain, also relevant for sequential motor movements and planning. And the thalamus is the relay center in the brain, which is all areas of the brain have to travel through the thalamus to connect to other areas of the brain. Also affected in fetal alcohol spectrum. Okay? So much broader regions of the brain are affected even by small amounts of alcohol. And then it's so interesting to me because in different individuals, for whatever reason, whatever other genetic material they're given during development, some individuals can have severe deficits with small exposure, small amounts of alcohol, and some can take large amounts of alcohol and have less deficits. In general, the greater amount of alcohol for the longer period of time during pregnancy causes more severe, but that's not always a straight correlation. Okay.
Is there an advantage to having the scan taken
She asked if there's an advantage to getting an MRI scan, and it doesn't do a classification like how far along it is. But yes, for a trained radiologist, so if they're given the question of, can you look to see if there's deficits consistent with the fetal alcohol spectrum? Yes, there are MRI criteria based that are consistent with fetal alcohol. So there are specific deficits to look for. Okay, so overall small brain, overall smaller frontal lobe, smaller corpus callosum, specific regions of atrophy in the cerebellum. So if the physician knows what they're looking for, they can be told and asked to look for that, and you can see that on MRI, even in children, absolutely. The difficulty lies with educating them. So that needs to be said on the MRI when you're taking it. You can't let the physician, when the physician orders it, you can't just say, order an MRI, because the physician who reads that, the radiologist who reads it, is different from the physician who ordered it, and they're going to do a basic read. Okay? And the term atrophy, right, which is less brain tissue, usually means loss of brain tissue over life. If you have dementia, right, you get atrophy as you age, but syndromes like this cause, because of exposure to alcohol, less tissue. All radiologists will say age-associated atrophy, or atrophy, they'll say nonspecific, right? So unless they're told what to look for, they won't call that as being noteworthy. They're looking for strokes and tumors, right? So they need to be informed. Mm-hmm. Then you bring a copy of the MRI. Now they give them to you on a CD. Yeah, you get it on a CD, get copies of the CD, and you bring it to somebody like the Wakeman Center or geneticist, somebody that's trained in FASD, and have them read it. It doesn't have to be read by a radiologist. It needs to be read. Yeah. Yep. Absolutely. Yeah. So, I think it's useful because that's information, right? And then you can use that when you apply for resources, all kinds of things. Here's brain damage. I'm showing you structural brain damage. But, right, it's still on the functional screens, as the panel mentioned, we still have to tie that to functioning, right? So it's still tied to functioning. But it's easier to do when you have structural picture than not. Yes.
However, we mentioned, the bringing smaller components not fully developed right now. Have there been additional studies on persons with FASD as they do with age, and what the prognosis of earlier dementia or other types of neurological conditions because the brain is not as informed practice?
That's an excellent question. I'm going to repeat that just for the videotape. So the question is, given that there are structural abnormalities found in the brain of individuals diagnosed with fetal or exposed to fetal alcohol, does that indicate, or has there been any research that's been done finding out how they age, and do they have higher risk of dementia and other age-related cognitive difficulties? It's interesting. I just gave a talk, I'm not even sure, maybe a month ago or so. I'm doing a series of lectures, and one of them was on IDDD, so intellectual disabilities, developmental disabilities, and their relationship with dementia. And there isn't any research, right? Because the research on FASD itself, just making the diagnosis and getting resources and stuff. And so following these people over time, there just hasn't been any good longitudinal studies or looking at dementia in these populations. But certainly from the research in Down syndrome, autism, intellectual disability, right? Down syndrome obviously has a direct relationship because of specific chromosomal abnormalities and the genetic components of the disease. What happens in the brain is directly related to causing early Alzheimer's disease. So that's sort of different, but certainly the research shows that when you have a vulnerable brain, you're not going to age as well as somebody who doesn't have a vulnerable brain. So they do tend to have, we do know that they have increased mortality. And they can have, there's other, unfortunately, physical, they can have cardiovascular defects, they can have kidney and liver defects that result in medical complications that lead to earlier mortality. And so there's earlier mortality, so often we can't follow some of them into adulthood to see if they get dementia, but I would certainly imagine that that would be the case. But I don't have any research that I can cite to that directly. Okay, so then we look at, now this is my domain, right? So there's the medical stuff. You can look at the face features. But really, for the broad spectrum of FASD, obviously those that have the facial dysmorphia are pretty obvious to medical providers, and that gets diagnosed in infancy, right? So you can tell if somebody has a cleft palate, or if there's something wrong with their eyes or their head, right? So that gets noted, those medical findings, even though then some medical providers don't relate that to fetal alcohol exposure, but those abnormalities are usually found. But the broad spectrum of fetal alcohol, right, really relies on this third domain, right? The intellectual, the cognitive functioning domain, right? So the CNS, this is what's really important. And this is what providers send them to me, right? And then they said, you need to make this so I have a high suspicion of alcohol exposure, but they don't really meet, for sure, all of the facial criteria, the physical characteristics. So it's really the neuropsych for many times that's the deciding factor. For Dr. Weisbrunn, who works, in Madison, when I've sent the neuropsych, that often has been the deciding factor. Okay, this looks like the profile for FASD, and that can clinch it. So somebody who knows what they're doing, that can really be the deciding factor in making the fetal alcohol spectrum diagnosis. So we're looking. Oh, sorry. In the global cognitive, they're looking for cognitive functioning that's at least 2 standard deviations away from the mean, okay? And then functional deficits have to be at least 1 standard deviation lower than the mean for that age group at any age. So this can be in childhood, adolescence, or adulthood from their peers, and at least 3 of these domains. These are the functional domains. So this is what I assess when I'm looking at this. And I throw a full battery because in FASD, anything could be impaired. So you want to look at attention, all aspects of executive function, all aspects of attention, all aspects of memory, learning and memory, visual spatial, visual perceptual, visual construction skills, fine motor, gross motor, right? So the batteries are much longer than they are for other diagnoses, like ADHD we just looked for, right? So unfortunately what happens in traditional neuropsych, if you don't come in, right, they do these pre-screening with the secretaries and all the hospitals. So if you don't tell them, this is bizarre to me because we used to be trained, I was trained, neuropsychologists used to be trained to do a differential diagnosis, right? But now, unfortunately, insurance companies dictate so much of what we do. They only give us so many hours to test. You can't do, I used to do 20-hour batteries. You can't do those anymore. And so now the secretary is supposed to screen, what do you think you have? I'm like, so you want the patient to make the diagnosis before they come in to get a diagnosis to see if they meet criteria for any diagnosis. We're the ones who are supposed to make the diagnosis, right? They're supposed to come in, get a thorough evaluation, and we tell them if they meet criteria for anything. But now insurance dictates so much since they have limited time. So the most common diagnosis, so most parents will say, well, they have attention problems or there's behavior problems, and what's the first thing a neuropsychologist is going to think? ADHD. Right? We don't have ADHD today. And unfortunately, it includes a lot of people who are misdiagnosed. Because absolutely, FASD has attentional problems, but I'm going to talk about the difference between ADHD plus ADHD in FASD. okay, and ADHD in autism. Very different birds, okay? So you're only getting a piece of the picture then. Yeah, they might have attention problems, but the reason that's important is because the medications don't work the same for ADHD in FASD nor in ADHD in autism as they do in pure ADHD, right? It's only a piece of the puzzle, okay? But it's so easy and it's so common that they only assess for that. They don't even give these other tests. So they're not even given visual spatial or memory or, heaven forbid, any of the social perception or social problem solving tests. Those are never given. So you miss that piece, okay? So you need to mention that, so that's unfortunate, but that's why education helps. And a lot of them also don't measure adaptive functioning either. So that needs to be a very large part of the evaluation because how the impact of these deficits on functioning is highly relevant and needs to be directly assessed so that you can go to the ADRC and do the functional screens and then they'll meet criteria for that. So that piece is very, very important to be done for the neuropsych, okay? And then also, obviously, there needs to be either the confirmed exposure to alcohol or this unknown but highly assumed possibility of exposure to alcohol. Okay, so the full diagnosis requires documentation of all three facial abnormalities, documentation of growth deficits, so they have a slower than average growth physically overall, and then documentation of CNS, as we talked about, so microcephaly, height, weight, brain, etc. Then partial FAS medically, there has to be confirmed in utero exposure to alcohol, so that is required. They need some evidence of facial dysmorphia, but not all three cardinal features are necessary. And there has to be some evidence of either the growth retardation or some type of CNS abnormality. You can see sort of less heavily weighted criteria, right? So we're expanding, right, broadening the spectrum from the full criteria to now partial, which meets now fetal alcohol spectrum, okay? Age-related, this is what used to be a term which studied quite a bit in the research as DSM-5 was coming out, alcohol-related neurodevelopmental disorder. And the criteria is you need neurocognitive impairment. So this is the criteria for the neuropsych diagnosis on DSM-5. We need behavioral dysregulation, and you need deficits in adaptive functioning. So we are really, the focus is primarily on the CNS piece, right, in the absence of significant facial and physical identifiable features, okay? So there's a huge reliance on the CNS piece, okay? This is the new criteria. So this is a neurobehavioral disorder associated with prenatal alcohol exposure. You guys can read this. I'm not going to go through this, but obviously heavy reliance on cognitive and adaptive functioning and emotional and behavioral dysregulation, and there's discrepancy between performance on tests and the functioning in real life. Okay, so that's key. And then, of course, not better explained by any other criteria. I talked a little bit about alcohol. I'm not going to go into that too much. Generally, the higher you use, the more alcohol you use, the longer you use it, the more deficits, but there's not a strict correlation. It also depends on other health factors of the child and other genetic conditions that either can modify that and make you withstand that traumatic insult to a greater extent, and others tend to be more vulnerable to even a little amounts of alcohol. And so the criteria currently are what? How much alcohol is safe during pregnancy? None. Zero. The other very, very important thing in fetal alcohol spectrum individuals is there are primary difficulties, right? So we know that there are structural changes in the brain, and we know that, that from the neuropsych, even if we don't see the brain, we know there's significant impact on a variety of areas of cognitive functioning. And then there's also, so just those deficits, if you have a memory impairment, that's going to influence how you're going to function in day-to-day life. So it's a direct impact of the impact of alcohol on your brain. But there are also so many secondary disabilities that develop in fetal alcohol spectrum individuals over their lifespans that don't in other diagnoses, okay? So they often, you know, they come from families often that have significant familial turmoil. They're often in foster care placements, right? Because if you think of their mother drank these drugs and alcohol, often there's maybe mental health issues or maybe cognitive issues or intellectual issues in the mother. Certainly familial issues, she might have consistent dysphagia.
And through our anxiety, they're starting to when they ask, I could think there's something else here. And so we did some genetic testing, and we're finding that a lot of some of these kids, the parents have the genetic disorder with intellectual disability, and so then they're anxiously grieved. So it's never just one thing.
Absolutely, absolutely.
And trauma and prematurity and all.
Yeah.
Sorting it all up is the fetal.
Yeah. As she mentioned, right, in fetal alcohol, it's never one thing. The parent, the mother often has we're finding genetic abnormalities. There's nutritional abnormalities in addition to the effects of alcohol. There's turmoil. There's trauma. Often there's abuse, both of the mother themselves during the pregnancy, the child, after the child is born, there can be abuse. There's neglect, if the mother continues to drink. So many other issues. There's school issues because there's emotional behavioral dysregulation. The schools don't want them. They kick them out. So then that causes secondary problems because nobody wants me, nobody loves me. I can do it, I can't do it. I can do it, I can't do it, right? So this roller coaster ride of emotional behavioral dysregulation that really influences then all relationships that child has throughout their life, and that destroys resources and relationships that could be supportive. Even parents, right? I've known many parents who cut themselves off. That's it, I'm done. I've given you what I can. You're 18. You're on your own. They just can't do it anymore because it's too much turmoil. So many of these other secondary issues, inability to find appropriate living while they're with their parents or on their own, and then certainly trouble with the law, huge. Okay, so neuropsych. We've talked about a wide range. So the neuropsych data. What is my time? Right. What time are we going? Okay. There can be a wide range. Certainly there's individuals who meet criteria with IQs below 70, equivalent or below 70, and meet criteria for intellectual disability, which was previously known as mental retardation. But many individuals on the spectrum do not have IQs lower than 70. Okay? It is more commonly impaired in FASD than it is in autism. Okay, and autism usually have higher IQs, in fact, usually higher than average in autism. That's rarely the case in fetal alcohol spectrum. So even if when they don't have intellectual disability in FASD, they often still have low normal and much less commonly average IQ compared to other diagnoses. So that's typically not the case in ADHD and autism. Okay? And we can see impaired intellectual ability even in the absence of facial features and growth retardation. Okay, so this is very important. So that's why these diagnoses have come about, because the research has shown in cases where there's known alcohol exposure in utero, even when they don't have the facial features, they can have mental retardation that's attributable to the alcohol. So we know this from research, okay? There can often be a discrepancy between the verbal and the nonverbal IQ, but that can be in either direction. So some have a higher verbal, some have a higher nonverbal IQ. The IQ does correlate with psychopathology, so typically the lower or worse IQ is, the greater the psychiatric and behavioral disturbances. Okay? And we do know that moderate exposure, at least of alcohol in utero, leads to a decrease in IQ in young children. And then moderate alcohol, even in the first couple of trimesters, IQ is associated in African American children only. So there's some interesting discrepancies in the research on the amount of alcohol exposure and also some cultural and socioeconomic factors that play a role. Okay. Now, executive functioning is probably the most important area. I do a lot of testing in this area because this relates directly to functional activities of daily living and adaptive behavior skills, okay? So what is executive function? So our frontal lobe, here, right in the yellow, is the largest part of the human brain. It's what separates us from all other mammals, right? Our frontal lobe has connections to all other parts of the brain, and it's our executor. It's the one that makes the decisions. It puts everything together. It's our personality. It regulates attention. It regulates behavior, volitional behavior. You know, people think that behavior is on a choice, right? But our frontal lobe controls it. So if your frontal lobe is impaired, then you don't have control over your behavior. right? So it might look purposeful because we engage in behavior, but our brain controls it. And that doesn't mean that we volitionally can control it. And this is so huge in fetal alcohol because, right, the person with fetal alcohol, especially in adolescence and adulthood, they want to be able to do it on their own, but they can't quite yet, right? But we want them to, so we help, but they make mistakes. And it's this continuing battle because their brain is telling them they can do it, but their brain is broken, right? But your brain doesn't tell you it's broken. Your brain can look and say, oh, if I have a bone sticking out here, my leg is broken. But your brain does not go around and evaluate itself, right? What happens when the brain has a hole, and if you have a stroke or a deficit, does anyone know what your brain does? If you go around searching for the answer and your brain doesn't know it, what does your brain do? Yeah, your brain doesn't tell you, oops, I can't find that information, I don't know it. It makes up an answer. Anybody heard the term confabulation? Confabulation? It is really, it's only seen in fetal alcohol spectrum and in alcohol dementia. That's it. Right? You don't see it in autism. And they don't, it's not lying. It's not malingering. It is not making up information. It is the brain searching, finding, oh, okay, well, that's the answer, and giving you that, and that's the answer. It's the brain impairment in the frontal lobe that does confabulation. It is not purposeful lying, of course, to families and people, and certainly law enforcement. It really feels like lying, right? So documentation of this and labeling of this in neuropsych is very, very important. Right? So overall, the definition of executive functioning is the ability to maintain an appropriate problem-solving set for the attainment of a future goal. Anybody think that's impaired in FASD? Yes.
My experience that just happened yesterday was let's clarify when you go see the doctor this afternoon what you might want to say, what social worker it was. And he's like, well, I don't know what's going to happen. I can't see the future.
Right, so I can't tell you what I'm going to say until I get there.
And I don't know what plan is. I don't plan. Why would I plan? What's going to happen?
Exactly.
So
what's the purpose of it?
Yeah, so you think about all the things we do with plans. Again, what we wear in the morning, what we're going to do this afternoon.
Because we're guesstimating, right? We're guesstimating weather, we're guessing what we have to do. Should I look presentable or can I go to work in my scrubs, right? They don't ask those questions.
Nope.
The frontal lobe also does time management and really the concept of time, right? People don't understand that being able to understand all these abstract concepts, right? Loyalty, friendship, time, right? Because what is time? It's an abstract, vague, I mean, we can watch it on the clock, so they can tell time, but they can't estimate time or tell you how long something's going to take.
One thing well, the other thing is, if in fetal alcohol, let's say it's serious, and I touched it with my foot, but if people with fetal alcohol are relying on visual memory, putting it, and you're not, so you're looking at, they can tell you what everybody else did, but they can't tell you what they did. So, but they can tell you you had a blue shirt on right now. They can tell you that this. So, but they can tell it's everybody else.
Right, because they're looking out.
Yeah,
that's exactly right.
The other piece of it is, it takes higher order thinking than they have is to implant themselves into the thing.
Yes.
And then they don't have self-awareness, they don't have any of this. So they can tell you all sorts of facts, like when you get into law enforcement people about what other people did that they didn't do.
Yes.
And they can believe whatever they did because they didn't see themselves do it because they're the camera operator.
Yes. Mm-hmm. Right? Between the ages of 7 and 9, there's a huge developmental period of the frontal lobe, and that's when the brain starts to be able to start understanding the concept of time. What is time? And it also is the beginning of the brain's ability to teach observing behavior, listening to feedback, and then using that feedback to then monitor, regulate, and change your own behavior and response. So that process develops between 7 and 9. But if that's right, developmentally, we know that that's disrupted in fetal alcohol spectrum. So they don't learn the ability to utilize information that's given to them to apply to themselves, to see themselves from that right perspective taking outside of themselves, and then not only that, but what is the impact of my behavior on other things, right? So that interactive of looking, perceiving from both sides doesn't happen. And that really, this is all awesome. Now this relates to, yes, go ahead.
Well, I just want to, this is a big, big problem. Yeah, hopefully, I think my daughter. She has helped. She's big, big, big. And, you know, she's the sheriff. You know, and she always has. She's the rule.
There's only one way the rule works. And you don't dare change the rule. They can't see the, they never break the rule. Everybody else breaks the rule.
And we're going to talk about some testing that I do that looks at this. This is a big area, and there are tests that measure this. So the new test out, so there's social cognition, social perception, theory of mind. So there are tests now that measure these domains, and you can get numbers and scores that relate to functioning. Yeah.
So when you have a group of people, individuals, we're all okay, here's the thing. If Monica's upset because Amanda is being Amanda and kind of controlling a little bit, being a little loud, how do I explain to Monica that that's just part of her diagnosis and that's something she can't control? Because right to her, she just gets bossy, but she can't control what to an extent she might be able to, but not completely. So how do I explain that?
Right. That last piece is the most important. Sometimes you can, but not really. That's key. Because the truth is, it's brain. It is brain-driven, right? But this, I get this from teachers all the time, too. Well, I know they can do it because sometimes they can do it. Oh, right. And ADHD, same thing. It's like, hello, by definition, it's a roller coaster ride. Sometimes it clicks and sometimes it doesn't. It even happens for dementia, right? Sometimes they have good days and sometimes really bad days, right? Yes, absolutely. There's so many other factors. Yeah. So I think the most important thing is say exactly what you said, except leave out that last part. Don't say except sometimes they can. Because we need, right, they need to understand that it's brain behavior, but we can learn strategies to help modify our behavior. So I can say, I know this is my brain. Now here, this is my big rule with E words, right? Excuse versus explanation. FASD is an explanation for what's happening in your brain. It is not an excuse that lets you do whatever you want. Knowing that you have fetal alcohol spectrum and have these deficits associated with it doesn't give you free rein to terrorize the rest of the group home. That means you have to work extra hard to learn strategies to cope with that and tell people when you're having a rough day. And give you feedback immediately. Yes, absolutely. It's about prevention, telling you triggers.
Intervene before we get to I don't know about that.
Yes, whenever it's correct. Yeah. Right, because you can hit a point. That's absolutely true too. You hit a point, you got to wait till that's over before you can come back. I like to use the term. I'm going to hold a mirror for staff to hold a mirror up to you, because this is what happens. They don't look outside of themselves. Okay, so literally holding a mirror, sometimes videotaping on your phone if you ask permission, and showing them back. This was the truth, right? Because I'm saying, I'm not pointing fingers, I'm giving you feedback. I'm giving you feedback about both of your behaviors. So you, Diane, you need to know how you're acting and how Jackie's acting. Jackie, you need to know how you're acting and how Diane is acting. You both need to know, both of you, right? So that's what you say as a stats provider. You don't say, Diane, you're only looking at Jackie. What about you? And Jackie, you're only looking at Diane.
And also, I heard you take the judgment out of it.
Yes.
It's good, bad, this is what you should do, something you shouldn't do.
Yes, I do lots of role playing. Absolutely.
And so I put mirrors on the wall. So they had to look at themselves. So they could actually remember that they were there. Mirror type.
Yeah, if you see that, they're missing that. And they need that repeatedly, right? I'm giving you feedback, and that's why I'm saying. But one lesson, you know, I like to say, one lesson we all need to learn in life is there's always more than one side of a story. I like to do this example in my office. So if I have a family present, I rearrange. So like I have some chairs and stuff, and I'll have somebody, you know, sit here looking out the window. I'll have this person looking at this place, or this wall, and this person looking towards this wall. And then I have somebody come in and do something, and I have everybody independently. I get everybody out of the room, and then I interview everybody and tell me what they saw. Okay? So the same event happened, right? And then I get 5 different stories. And then I ask, whose story was correct? Anyway? Everyone! So it's a perfect, so you could do a little role play in the room. Everybody? Okay? Sit here, you sit here, you look, and you're looking over here, and you're on your phone, and you're over here watching TV, and you're over here talking to her, and you're doing this, you're washing clothes, and something happens, and then everybody else, you interview one at a time. What did you see? What did you hear? What did you see? What did you, right? And then you say, who's correct? And you show them, you're all correct. You each saw a piece of the puzzle. Yes. What else?